Thank you for your kind invitation, and thank you for being here so early in the morning. A special thanks to my guests. And I had some trouble in coming here, some problem, but I will not miss this opportunity for any reason in the world. Just a request. Can we change my picture here? So I will give you a better one next year. So let's try. My conflict of interest for this trial is, thank you so much, it's very strong, I have to say, because cervical cancer, I believe it's my karma. I am a gynecological oncologist by training, and I treat only gynecological cancer, but among all the gynecological cancer, cervical cancer to me are the worst. Are the patients with a so painful disease for which we do not have enough therapies, and most of these patients are young patients with small kids, and the tumor is very symptomatic. The tumor is evident and preclude any possibility of social or personal life. In general, I have a very good relationship with my patient. The only patient for which I have a relational problem are cervical cancer patients, because they are really angry and upset against life, because this is a terrible tumor. My conflict is that when I think about KNA-18, I do not think about MSD. I'm sorry, MSD is sponsoring this symposium, but this is my trial, because this was my idea. I do remember in 2017, I came back from ASCO, where the results of the Pacific trial has been presented with immunotherapy in the adjuvant setting after chemoradiation in lung cancer. And the results were impressive. And over the flight back, 9 hours, so I have a lot of time to think, I was thinking what we can do with this data for our patient. What is the setting in which we can integrate this strategy? And the only strategy, the only place for me was locally advanced cervical cancer. You know that in 1999, 5 randomized trials reported that when we combine cisplatin, weekly cisplatin, to chemoradiation, to radiation therapy, we were able to increase by 6% overall survival and by 8% progression-free survival. It's important to keep in mind this number, because 6% can seem nothing, but it is not. Because thanks to this trial, since more than 25 years, concurrent chemoradiation has been the standard of care for patients with cervical cancer. But something did change in the reality. I don't know if there are radiation oncologists in this room, but when I did decide keynote, I did approach the world of radiation oncologists, and I did realize the big, huge step forward that radiotherapy technique has done in the last year. And modern radiotherapy, image-guided, volumetric, adaptative radiotherapy, has changed completely the treatment of cervical cancer patients. When you use this technique in combination with external radiotherapy, you reduce toxicity. But when you use this technique in combination with the brachytherapy, you increase local control. And there is a big difference between cervical cancer and endometrial cancer. You will never have a trial in endometrial cancer in which local control impacts in overall survival. This is not true for cervical cancer. Local control for cervical cancer as a rule increase the survival of our patients. And so when we designed the trial, we have several radiation oncologists as counselors in helping us in defining what should be the radiotherapy in this trial. Why? because if you do not use an appropriate radiotherapy, you will never be sure if the drug you are adding really works or simply counterbalance an inappropriate radiotherapy. So we stick on this principle when we design the trial. Immunotherapy works in cervical cancer. We already had the data in metastatic setting. Cervical cancer is a disease in more than 90% of cases related to HPV infection. HPV means PD-1 expression, means tumor infiltrating lymphocytes. So there was a strong rationale to explore immunotherapy in cervical cancer, and there was a rationale in exploring in combination with chemoradiation, because in lung cancer, but also in other diseases, we have evidence that radiotherapy can work as a primer, inducing an immunogenic death and releasing a new antigen. And that was the principle why we designed this trial. Just a few comments about the trial. The standard arm was obviously represented by concurrent chemoradiation and brachytherapy, which is not optional, is part of the treatment. And the experimental arm was the same backbone plus pembro in combination with chemoradiation at the dose of 200 milligrams every 3 weeks for 5 cycles, and then followed as maintenance at the dose of 400 milligrams every 6 weeks for 15 cycles. 15 cycles, more or less, represent 2 years of maintenance therapy. Why 2 years? When we designed the trial, we were completely blinded. We did not have any data in any other disease. We choose 2 years because when you look at the epidemiology of recurrence of disease, 80% of recurrence in cervical cancer occur within the first 2 years. So we simply design a trial that in our mind should protect the patient for the maximum time risk after the completion of chemoradiation. What patient? The patient for higher risk. We use a FIGO 2014 classification because this trial was designed in 2018. And in 2018, the new classification was just entering, and not all the centers have already implemented, so we use the older one. But I want to say that FIGO stage 1B2 to be node positive are FIGO stage 3C now. These patients are high-risk patients. And FIGO stage 3 and 4A could be enrolled regardless positivity of lymph node. The stratification factor. This was a global trial, more than 150 centers in 32 countries. We push for the modern radiotherapy, but we did recognize that this cannot be everywhere. And so one of the stratification criteria was the quality of radiotherapy, because we wanted to be inclusive and give the possibility to all to join the trial. And obviously the stage of disease and the planned dose of radiotherapy. Why 70 gray? Radiation oncologists will teach us that 70 gray is a very low dose of radiotherapy. And in fact, you will see the median radiotherapy dose that was received by this patient is 87. Very high, very good, in the range of the good quality radiotherapy. But why 70? Because we had a lot, 30% of the patients enrolled in the trial were Chinese patient, and our counselor suggests that for Chinese patient, 70 gray is the appropriate dose, but you will see why, how many patients did receive this dose. The trial has two
Why 5 cycles of cisplatin instead of 6?
Because we discuss a lot about that. You will see a lot of patients will receive 6 cycles, but the 5 cycle was what all the counselors reported to be the minimum acceptable number of cycles to combine with chemoradiation. Thank you for your question. The trial has 2 primary endpoints, and please, I love the idea, so please ask a question. This is not a talk, this is a discussion among colleagues. I appreciate your question, please do it. If something I say is not clear, stop me in any moment. I love the idea to have interaction.
Do you believe that these results can be reproducible with radiotherapy techniques less than...
We are writing the paper right now. The meeting with all the radiation oncologists involved in the trial is next week. We are writing the paper to provide all the detail of the quality of radiotherapy that has been provided here. You probably, it's important for you to know that all these centers were selected because we need to be sure they provide good quality radiotherapy, and we had an external vendor that did review all the Bravo, thank you so much. And if they were not good, they came back to the center, explain how to do that, and they modify. And this is very important because this trial, and we will publish this data, this trial had also the opportunity to have a kind of educational process, and we will describe this process in the paper. The trial, as I told you, has 2 primary endpoints. This is a curative setting, so we discussed this PFS, OS, and we insisted to have overall survival, because when you do a trial with the 2-year maintenance in a curative setting, you should be able to demonstrate overall survival. In my opinion, PFS was not enough. And the trial has several interim analyses, and we get PFS at the first interim analysis. We get overall survival at the second interim analysis, but I will show you today also the data of the final analysis that were presented by Linda Duska. This is an ENGOT GOG trial and rest of the world trial, and Linda did present the data in ASCO last year. I want to show you that overall survival was not median overall survival, because this patient has a very long survival, was 3-year overall survival. We enrolled a kind of huge number of patients, and this was done during the pandemic, I have to say, because the trial enrolled between 2020 and 2022, and it's impressive, the job of our radiation oncologists that during this very tough moment for the global health were able to treat this patient. We enrolled more than 1,000 patients. 32% of patients were screening failure. The main reason of screening failure is that they were not considered enough risk for the trial. Why? Because we were very strict in the rules to define node positive. In order to be enrolled and in order to be defined a patient as a node positive, the shorter axis of the lymph node should be 15 millimeter. And if the patient was evaluated with the PET-CT, he should have at least 3.4, because we really want to be sure that we were enrolling a higher risk population, and the experience of CALLA trial was very recent, and we were scared because CALLA was negative, in my opinion, and Brad Monk is here somewhere, he will kill me, but CALLA was negative not because of durvalumab instead of pembrolizumab. This is the idea that Brad has. To me, CALLA was negative because the population was not enough risk. When you look at the forest plot of CALLA, in patients with positive lymph node, the forest plot, the benefit of immunotherapy is evident. And so when they invited me to comment CALLA trial, can you imagine? Brad was presenting and I, with the competitive trial, was the discussant. When I discussed the trial, I underlined that to me there was a signal in the higher risk population. And so we try to have really a higher risk population. And we had it. Almost all the patients were PD-L1 positive. 56% of the patients have stage 3-4. 85.
All patients were assessed with PET-CT at the first.
Yes. Yes, absolutely. The patient in which the positivity of lymph node was only evaluated according to PET-CT did repeat PET-CT. We gave in the same time of MRI. The trial was very rigorous from this point of view. Every 3 to 4 months, there was a MRI for the patient that followed the disease with MRI, and PET-CT for the patient in which the lymph node were only seen with PET-CT. The trial was very, the timing of evaluation was well detailed and also symmetrical between the two arms. 85% of the patients had positive lymph node, 22% in the para-aortic area, and this is what I want to stress. About 90% of the patients receive what we call the standard and modern radiotherapy, and only less than 10% of the patients, which were Chinese patients, receive a dose less than 70 gray. The median number of cisplatin was 5 in both arms, and this is very important for radiation oncologists and also for me. I learned a lot. The overall treatment time. You know, the overall treatment time, according to Embrace, should be 46 days, 45 days, maximum extension to 50. We were 52, with 35% of the patients receiving treatment in 50 days, which was a miracle considering the pandemic. And this number to me did not mean a lot at the beginning, but I think that for the radiation oncologist here means something. This is a picture that describes the quality of radiotherapy that was provided into the trial. What I learned is that this parameter, it's very important. This is the total equivalent dose calculated to the volume of the tumor, not to a point. Please correct me if I'm wrong. And this was 87, which is in the range of what Embrace is the Bible of radiotherapists, I did learn, and gave a lot of information about how to consider a good quality radiotherapy, and they said that the total EQD2 should be between 85 and 90, so we were very happy to be there. As I told you, most of the patients receive modern radiotherapy. The total dose given by brachytherapy was 44, and 56 in the lymph nodes. There are other information that probably are important for you, and this is one of them, the interstitial brachytherapy. 23% of patients receive interstitial brachytherapy, which is lower with respect to the number of patients in Embrace, but we have two possible explanations for that. One is that, again, the pandemic. Interstitial was not that easy to arrange in all the hospitals, particularly in an emergency moment. moment as pandemic. The second is that the immunotherapy was combined with chemoradiation, and we are analyzing the data. We do expect that this increased the overall response rate, probably reducing the necessity of interstitial brachytherapy that is, please correct me if I'm wrong, something that is done when still at the end of chemoradiation, the volume is still very high. Do you want me to work with you as a radiation oncologist? I learned a lot about radiotherapy. And this is the progression-free survival that we get at the first interim analysis at 2 years. About 11% more patients were free of progression with an hazard ratio of 0.70, 30% reduction in the risk of progression, and this is the progression-free survival at the final analysis. And as you can see, it's very consistent, and the curves remain very well separated at 3 years, 55 versus 64. And this is the overall survival that we get at the second interim analysis. At 36 months, 75% of the patients in the placebo arm were alive with respect to 82.6. That means 8% increase in overall survival at 3 years on the top of modern radiotherapy. Just to remember, the 5 trials that transformed forever the treatment of locally advanced cervical cancer, adding cisplatin to radiotherapy, provide 6% increase in overall survival. And this is the final analysis that was a 3-year overall survival. As you can see, with the more number of patients, the number were maintained. At 48 years, it seems that the curves overlap, but you can see here how many censored patients we have. And so don't be confused by the shape of the curve. And I want also to say that if you look at the interim and the final, the curves are basically identical. So I think we can be really, really sure of these results. Regardless, 33% of the patients originally enrolled in the placebo arm did receive chemotherapy after progression, because you know chemotherapy is available now also in combination with chemo. So with the 33% of crossover, the curves remain very well separated, and to me it's very, very, very consistent. I have to say, sometimes I do not understand the decision of the authorities, because the trial was powered not for the subgroup analysis, but for the intention to treat population. But based on this subgroup analysis that are event-driven and hypothesis-generating only, the authorities did approve the drug only for stage 3 and 4A. That means patients with vaginal and parametrial involvement, bladder and rectal involvement, regardless the lymphnodal status. But in Italy, we get the approval 2 weeks ago. They said simply stage 3 and 4A, and I think I will use also this drug in my patient with the positive lymph nodes, because these patients were in the trial is positive. The magnitude of benefit is different, but because these patients are more cured, and so less events, but there is no reason to think that it does not work.
In what patients would you consider to use chemotherapy induction?
Chemotherapy, to me, in this moment, in no one. And I have another talk later on in which I will explain my reason, but it's good to discuss with you now. I'm sorry, very sorry to say that I have some problem with that trial. First of all, immunotherapy is not the antithesis to induction chemotherapy because the population were completely different. So if I have to think about an alternative to induction chemotherapy, interlace scheme, I think to modern radiotherapy. I don't think to immunotherapy. The population were completely different. 76% of the patient, 86% of the patient in interlace were stage 1, 2. So it's more similar to the population of the EMBRACE trial, in which modern radiotherapy provide exactly the same benefit that in interlace we have with induction chemotherapy and old radiotherapy. In addition, I do not want to risk toxicity, worsening in quality of life. So I do not use interlace in my practice. I know that some centers do that. And my last concern is about the methodology of the trial. I study a lot the methodology of the trial, and I really now look at this aspect that to me is very important. So the interlace trial was at the two primary endpoints, progression-free and overall survival, analyzed in a hierarchical way. So you have to get PFS. If PFS was positive, you move to the overall survival. The trial reported that the advantage of induction chemotherapy is in reducing distant metastasis. But when you look at the methodology of the trial, that was the question before, the CT scan was not done every 3 months, every 4 months, every 6 months, symmetrically in both treatment arms. CT scan was done at physician discretion. So how can you sure that what you have reported is true? And when you move to the overall survival, at the beginning the trial should enroll 700 patients, then was reduced to 500 patients, and for 500 patients they did request 170 overall survival events. If you look at the trial has been analyzed with 100 overall survival events. That means that 41% events are missing. That means that the power of the trial more or less is 0.6. That means that if you launch your coin, you have the same chance to find a positive or negative trial. I'm struggling with that, and I'm struggling with the impact that trial is having on the population. Because it's not only a matter of additional toxicity, it's a matter of jeopardizing the possibility to receive chemoradiation. I saw a lot of patients in second opinion now in Italy that are able to have 1 or 2 cycles of cisplatin concomitant to chemoradiation because of the tail of the hematological toxicity. And you can tell me how important is that we have 5 to 6 cycles of concomitant cisplatin. Or another thing that I am observing is that they receive 6 cycles of weekly paclitaxel and then start chemoradiation 1 month, 2 months later, which is a very terrible thing because we have data suggesting that this way is a way to induce chemo resistance and radio resistance accordingly. So the implementation of interlace is very dangerous in the world. And I do not believe in the data. The control arm is absolutely inappropriate. Only 30% of the patients receive the modern radiotherapy, and I do not believe neither in the storytelling that this is a trial for the country in which radiotherapy is not so good, because 70% of the patients were enrolled in England, 20% in Mexico, but not all over in Mexico, in the National Cancer Institute of Mexico, 8% in Italy, where we have good radiotherapy, 7 patients enrolled in India. I mean, I really want to know if in this country, where there is probably no modern radiotherapy, but do we have enough oncologists to perform 6 cycles of chemo? there are a lot of open questions about that trial. I know that several people has implemented. I hope that this will not impact the curability of cervical cancer patients over time. What about toxicity? Imagine when we were running the trial that for the first time we use immunotherapy in combination with the radiotherapy, and we were a little bit stressed about the side effect. It was nice to see that the grade 3 or higher side effect with respect to placebo treatment related were 8% more. Serious were 6% more. Discontinuation related to treatment, there was a 5% difference between placebo and pembro, and the discontinuation of any treatment, 0. No additional death. And when we look at the immune-mediated adverse event, obviously this is what we do expected. Grade 3 or higher, 5% with respect to 2%, serious 4% with respect to 1%. This is the final picture, not the interim analysis. This is exactly what you have to expect. And these are the most frequently reported toxicity. As you can see, anemia, nausea, and diarrhea were the most frequently reported toxicity, but you can see the picture, the difference between placebo and pembro, very, very, very similar. Most of the toxicity grade 1, 2. And I have to tell you, we were particularly stressed about diarrhea because this is a potentially overlapping toxicity between immune-related colitis and post-radiotherapy colitis, but you see here no difference. As for immune-related toxicity, as expected, thyroid dysfunction were the most frequent, hyper and hypothyroiditis. We have some level of gastritis, but very, very, very similar. Colitis, very similar. Adnexal insufficiency, very similar between the two treatment arms. This is what now we use with immunotherapy. Based on that, I really think this trial, my trial, not MSD trial, is the new standard of care. I would like to say for all people with locally advanced cervical cancer, in the reality for stage 3 and 4A, but whenever you can, please use, because it's just an economical restriction of the indication. The trial was powered for the intention to treat population, and the trial is positive for the intention to treat population. And this is a curative setting. I just want my last message. We have immunotherapy in combination with chemo in the metastatic setting, which is good, which increase in PD-L1 positive patient overall survival by about 1 year. But in the best scenario of patients that can receive chemo, can receive bevacizumab, and are PD-L1 positive to receive immunotherapy, the median overall survival is 28 months. That means, as Rob Coleman says, to live longer with cancer is good. To be cured by cancer is better. This is a setting in which we can cure 10% more of our patients. I have no doubt that whenever I can, I will use immunotherapy in this setting. Thank you so much for your attention.
Thank you, Dr. Lorusso. ¿Alguien tiene alguna pregunta?
Thank you much, Dr. Lorusso, for your great presentation. Would be very good to have information about the local control, the relapses, where were they, and everything with regard to the local control and distant metastasis.
You are absolutely right, but we are struggling to provide this data because the trial, the primary endpoint for the trial was PFS and overall survival. And the database, unfortunately, was not designed to capture this data. But because we do recognize, particularly for radiation oncologists, the importance of this information, we are reviewing the data, if not in the overall population, at least in subset analysis. We are struggling with MSD to do that, but I want to do, if we do not convince them to do that, and we are working on this, I will review the data on the 80 Italian patient, at least to provide a flower of this information that it is very important for you. But I just want to ask a question, because I will discuss next week with MSD about this. The quality of radiotherapy that has been provided here, it's not enough as a surrogate evaluation of the local control. I mean, how is it important for you to see local control even in the picture of this number of testifying the high quality of radiotherapy?
I don't want to make a spoiler of our afternoon talk, because I will show some information about what do we learn about the EMBRACE studies. But it would be a surrogate of local control, but we also need to state a benchmark about what immunotherapy is helping us in this setting. So we will see it 2:20 in the afternoon.
That's perfect. What I can add to that is we have some information about the increase, a numerical increase in overall response rate, but it's overall response rate, is not the T response rate. So we cannot use this information as a surrogate of local control.
We found in EMBRACE 2 the high-risk patients with the PFS of 74 and OS 10% less than you have here in the 18. So
With a different population.
with a high-risk population, 3 to 4 and 1 are positive. So with this information, these numbers are pretty good, or these results are higher and better than we have in the high-risk population in EMBRACE.
Because I think that immunotherapy and radiotherapy works together, very well works together. And to me, I mean, what I did realize when I start approaching the design of the trial is the importance to work with the radiotherapists, to work together to design the perfect trial. No trial is perfect, obviously, but I wanted to have the best radiotherapy because I have the necessity to convince radiation oncologists that really immunotherapy can add something. And to me, it adds in terms of distant control, for sure, but also something happened at a local level, because radiotherapy can be immunogenic, obviously according to the dose, hypofractionation, and blah, blah, blah. But I think that this is a good marriage.
I would like to take the word on the 74% of patients that has interstitial treatments. Because in order to, we have the local control and overall survival that EMBRACE 2 has shown, we must have a higher standard treatment in radiotherapy and radiotherapy. And interstitial was 74% in EMBRACE 2.
In EMBRACE 2, in EMBRACE 1 was 46%. We have EMBRACE 1 when we decide this trial. Anyway, 23% is lower, no discussion about that. But again, we cannot anticipate what was the reason. If just an organization problem related to the pandemic, which is true, or if there was a higher tumor shrinkage that did not necessitate.
That's a good point, because the resources we have to do interstitial, for example, in Colombia, of 33 departments that has radiotherapy, just 8 to 10 departments can do
The same in Italy. The same in Italy.
One question. In clinical practice, when the patient progresses into chemotherapy or after the chemotherapy, what are you doing with this patient? Do you have any?
The question is the treatment.
What are you doing in clinical practice after the immunotherapy treatment with the patient that has progressed?
We use a second-line treatment. The question was if treatment after immunotherapy failure. Right now, we have tisotumab vedotin approved in Italy, but you know the magnitude of benefit is very small. We have just concluded another trial with an anti-trop, and we will see the results in 1 or 2 years. I think the best opportunity for this patient progressing during immunotherapy after immunotherapy is a clinical trial. But I want to tell you another thing. In this trial, there were 11% of patients, 11%, that did receive immunotherapy. They did not progress during immunotherapy, and they receive additional immunotherapy after progression. You know what I mean? Not patient progressing immunotherapy, but patient that did progress after 2 years of immunotherapy. 11% of these patients receive again immunotherapy. We are evaluating this data because I would not exclude the possibility, if a patient progresses after the conclusion of immunotherapy, to reintroduce immunotherapy in combination with platinum, for instance, according to KNA-18. We are analyzing this data.
How did the Chinese cohort do? And if they did
Very well.
If they did well, could we reduce, decrease the radiation dose to 70 to all non-Chinese patients?
I don't think we can do that for 2 reasons. Radiation oncologists will kill you and me immediately, and so no, I think that we cannot reduce. The reason why, Chinese patients seems to be genotypically different. In all the trial, they have the best PFS, the best response rate, the best overall survival. And also in this trial, when the Chinese cohort was presented, the curves were very good, probably even better, even though they use a reduced dose. But just for clarity, less than 10% of these patients receive less than 70 gray, and the Chinese population was 30% of the overall population. That means that also in China, there were patients that received the same dose. I don't think that based on that we can reduce the dose.
Yolo. Hi, I have a question. First, thank you for your talk. I have a question regarding the patient attrition in the progressive setting at the relapse. Do you have the data? Is there a difference between the arms regarding
Subsequent therapy?
Yeah.
I did show. Sorry, I will go back. I did show the data. We capture the subsequent immunotherapy mainly, and I can say. I'm sorry, yeah, yes. The number of post-progression therapy, as you can see, was balanced. A higher number of patients receive immunotherapy in the placebo arm with respect to the pembro arm, where still 12% of patients receive again immunotherapy. These are the patients I want to see in detail. And also most of this was pembrolizumab. And ADC, I guess tisotumab vedotin, which is the only approved, was very similar between the two treatment arms. And the rest is chemotherapy, single agent chemotherapy that, as you know, provide an overall response rate of 5% and a median overall survival of 8 months. So I don't think, even if there was an imbalance between the two treatment arms, I don't think that came from non-platinum chemo.
But do you have the data regarding how many patients didn't receive treatment?
Did not receive treatment? No. We can check about that, but I think they were quite balanced. Why you are worried about that? You think that this can underbalance the two treatment arm?
No, just to know how many patients can we lose when they relapse? How many patients are not able to receive treatment?
This is a very important question, and that's another reason to use the best drug we have as soon as possible. In my experience, in general, after chemoradiation, the patient is able to receive 1 or 2 next line of therapy. The attrition rate, where I lose much more patients, is from the 2nd to 3rd line. But it's a very important point to address.
What do you do if the patients have a residual disease after immune? How are you managing this? Are you making surgeries?
This is a very important question, and this is something that we usually discuss in our tumor board. If the patient is in the field of immunotherapy, we do not offer surgery. We offer immunotherapy based on this data. If the patient is a stage 1, 2, and is not receiving, we do evaluate usually with PET-CT after 3 months of completion of chemoradiation, because chemoradiation continues to work, it does not stop at the end of treatment. And if they have residual disease, we discuss with the patient the possibility of surgery. What kind of surgery is another matter of discussion, because you will see in ESGO in 1 month, I hope you will be there, some of you, a very interesting data comparing pelvectomy and simply or radical hysterectomy in this patient. And you will see the data are very interesting. So probably it opened the possibility of a less aggressive surgery. We usually do that. We fight with our radiation oncologist. We have also proton therapy, so we offer the patient for a retreatment with radiotherapy or proton therapy. But according to what I have learned until now, the contraindications are very similar and rely on the time interval from prior radiation therapy. So after 3 months, they never accept a patient for a retreatment or a boost or something like that. We retreat our patient, but they request a minimum number of 9 months, 1 year. Yeah.
Because Remy, Alina, Umesh, and Dr. Subgroup are running right now the clinical trial with Cosmos and Cosmos, that we will see how it will work in this setting, also with immune therapy.
That's very important. The only point is that you need to do something. So, I mean, after 3 months, when you see still disease and you are sure it is disease, in general, we take time. After 3 months, if we see something, we repeat a PET-CT after 2 months just to see if there is an evolution. But if there is an evolution, you cannot wait for 1 year before starting treatment. You need to offer something to our patient. And in that case, if it is just local disease, surgery is the best we can offer. If it is a systemic disease, we start the second-line treatment.
Doctor, what about the dose of pembrolizumab?
What about, sorry?
The dose.
Oh, we use according to the trial, because the problem was to try to reduce the access of the patient. During the maintenance setting, we use 400 milligram every 6 weeks. That means that for 15 cycles, that means that the patient has not to come every 3 weeks. During concurrent chemoradiation, 3 weeks is good because the patient anyway came from cisplatin. But during the maintenance phase, we use a 6 weeks interval.
And do you think that there is any possibility to reduce the dose to 2 milligram kilos, like in another pathologies, for example?
The data we have suggests that the 200 milligram every 3 weeks is identical to 400 milligram every 6 weeks. To the best of my knowledge, I do not have data of 200 milligram every 6 weeks. What we are trying to do now, because we collected the ctDNA in this patient. So what we are trying to do now is to use the information of ctDNA for 2 reasons. To try to select among the stage 1-2 node positive if there is an higher risk population that can get benefit, and also to try to de-escalate not the dose but the duration. So I'm very curious to see if you have a patient with the negative ctDNA after 1 year, it is so necessary to provide a second year of Pembro. We are working on this data.
Okay, thank you.
The escalation of duration, not the escalation of dose.
Okay. And what can you tell us about the patients, older patients? Older patients above 65 years?
It does not seem. We have cervical cancer is specifically a disease of younger patients, but we have older patients in this trial. I will show you the range of the. When you look at the age, we have patients of 87 years in the Pembro arm, 78 years in the placebo arm, and we did not see additional toxicity.